Care in Massachusetts, webinar number 3. My name is Kaylee Vitek. I'm the PNQIN Project Management Specialist on our maternal side, working very closely with our special team of project leads and the Levels of Maternal Care Task Force to bring you this webinar series and also to bring you the Levels of Maternal Care in Massachusetts. I'd like to introduce Dr. Sarah Ray Easter, who will be also giving her own welcome to this webinar today.
Terrific. Thank you, Kaylee, for that lovely introduction. I think we can advance to the next slide, which has technical details, which I'm happy to present, but certainly not qualified to do anything other than tell you how to use the emoji button on Zoom. But I think long story short, Megan Carey is our technical prowess maven. So certainly she can exist for technical support, and then we'll keep an eye on the chat as well as hand raising. So while we're hoping to have ample time for questions, if for some reason one of us is a little chatty, feel free to interrupt that flow, though I don't know anyone who's chatty on this team. If you'll advance to the next slide, I just want to put a huge thank you out there for the PNQIN team, who has sort of helped not only support this work, but arguably more importantly, champion this work. And then the team at the Betsy Lehman Center for Patient Safety, some of whom have unfortunately graduated from the team, referencing Natalia, but was critical to doing this work as well. And then of course, the amazing team at the CDC, highlighting Dr. DeSisto, who will be presenting the locate results momentarily. If you'll advance to the next slide, I will just review our agenda, my brief welcome ending in 3 minutes or so, followed by our locate results, which I think is why most folks are still here, or most folks are here. There's still updates, even though you had a little sneak peek a couple weeks ago. So we appreciate you taking time out of your lunch to be here. Godwin from the Betsy Lehman Center is going to share a little bit more about our Massachusetts specific questions. And then we're hoping to have time for Q&A and discussion before Dr. Zara helps be the closing panelist today, trying to make a baseball analogy in honor of the Red Sox, but failed. If you'll advance to the next slide, I will just sort of go over our webinar objectives, which are really to review the results, but mainly to provide an opportunity for y'all to ask questions and engage in the discussion about locate specifically, but moreover, sort of levels of maternal care in general, which we're hoping to provide a little bit more clarity on towards the end of the talk today. And then if you advance to the next slide, I think you'll have what officially was meant to be my start of the welcome, reviewing just a little bit of levels of maternal care, which I hope most people are familiar with at this point. But just advancing one more slide, you'll see the title of what informs this work, the Obstetric Care Consensus number 9, initially put out by the Society for Maternal Fetal Medicine and ACOG, along with other critical sponsors that you can see here in 2015, and then updated in 2019, kind of mid the work of this task force, to try to help address a little bit more, or address some of the questions that came up with a little bit more specificity from that first document. Even though there have been 2 iterations, the concepts behind them have not changed. And if you'll advance to one more slide, you'll see just kind of a summary table outlining sort of levels of maternal care, and then sort of patient level characteristics, and then hospital level characteristics. And so I think while most folks who are on this call, who, you know, at least most of the names that I recognize, and I'm grateful that they took the time to drop in, I think you're probably coming at things from the hospital perspectives of sort of meeting a requirement, or making sure that your hospital is sort of practicing at the standard of care set forth by our governing bodies, to sort of be the quote unquote best version of yourself. But I think part of that is actually being aligned in terms of taking care, or making sure your hospital is equipped to take care of the patients that you want to take care of. And so while, you know, it's tempting in sort of any graduated scheme that assigns numbers, human instinct is to want to be at the extreme of those, perhaps, I really think the idea of risk appropriate is what's key here. If you're not trying, if your hospital isn't set up to expectantly manage severe preeclampsia remote from that 34-week mark, or you're not sort of interested in being in a CREDA center, for instance, perhaps those are the types of patients I think that would align with what's set forth for a given hospital level of care. So this is sort of a summary from what I thought was most relevant from a clinical framework, but I just wanted to dwell on it a little bit more, even though I'm sure you've seen this slide, with the hopes that it could give people a chance to sort of be self-reflective about what makes sense for their center. If you'll advance one more slide, you'll see just sort of a summary statement of some of the objectives of this, right? And I think certainly that will be covered a little bit more, but just reminding people that the goals of levels of maternal care aren't about individual hospitals per se, but in my mind, the way I see it, more about the network, which is why I'm grateful to be hosting this on a PNQIN server. And if you'll advance one more slide, we can all sort of highlight barriers along the way, from the patient level all the way to the care region, which I think this is a recurring slide in a lot of my talks, just calling a spade and recognizing that everything has a rub, everything has risks and benefits. And so I hope that when Godwin shares his results today, you'll see a little bit more about some of the things that we've done in Massachusetts specifically to address these concerns, and things we're really proud of. And on the next slide, you'll see just a reminder of our timeline for Locate. Consider this our method section. So in April, we sort of wrapped up the Locate survey. We spent the next month or so getting to this mark of 100% participation, which I'm so excited about. Most of y'all are aware that we reached out to every hospital with a preliminary version of Locate results to make sure that some of the things where hospital self-assessment did not align with Locate assessment were actually indeed true findings and not a result of data entry. Today we are October 12th on the webinar number 3, with the idea that next week the amazing team at BLC is going to get Locate reports back out with more individual hospital level data that would be de-identified here, but your individual reports to try to help apply these to your local care environment. And I think if you'll advance to the next slide, I have the pleasure of just sort of reminding folks of some of the concerns about things that have come up along the way, which I'll gloss over briefly, but really trying to eliminate barriers to equity, because that's central to our PNQIN vision, and then reinforce this notion of quality collaborative care, which is here because you are here. And then I think the next slide just will give actually who you're here to see with 3 minutes over. Apologies, Carla. And I'll turn it over to Dr. DeSisto from the CDC to review results from her work and assessment. Thanks so much.
Thank you, Dr. Easter. Next slide, please. So as Dr. Easter said, my name is Carla DeSisto. I'm an epidemiologist at CDC in the Division of Reproductive Health, and I'm the lead for risk appropriate care work as well as Locate. Next slide, please. I know my colleague Jenny presented to you all about Locate before implementation in Massachusetts, but I wanted to begin with a quick reminder about what Locate does. It produces standardized assessments of levels of care, and it facilitates stakeholder conversations. We've accomplished number 1 already, and today I'll summarize those data. And my hope is that this presentation and webinar is also the beginning of step 2 here for Massachusetts. Next slide, please. I want to quickly note that Massachusetts was the first state to implement version 9.2 of Locate, and I want to congratulate all of you on reaching 100% participation. I know you all worked really hard on that, and it clearly paid off, so congratulations. Next slide, please. So the bulk of my presentation will go through the aggregated results for levels of maternal care, which has been the focus for Massachusetts Locate. Next slide, please. So overall, 57% of facilities had discrepancies between their self-reported level of maternal care and their locate assessed level of maternal care. 2 of these 23 facilities actually locate assessed higher than their self-reported level. And then the remaining 21 locate assessed lower than their self-reported level. Most of the discrepancies were only by 1 level, but there were 3 facilities that had discrepancies of 2 levels. So for example, maybe self-reporting as a level 2, but then locate assessing as a less than level 1. I suspect you're wondering how this compares to other states. So our average discrepancy rate for levels of maternal care is about 42% for other states that have completed locate. So this is definitely within, I would say, our range of normal. And I also just want to point out here that there were only discrepancies in 11% of facilities in Massachusetts for neonatal levels of care, and the average from other states is about 39%. I know neonatal wasn't really the focus for Massachusetts, so I'm not going to talk about that any further, but I just wanted to note that quickly. And then on my next slide, I'll talk about levels of maternal care assessments further. So overall, 9 facilities reported self-reported being a level 1, 17 self-reported being level 2, 7 self-reported level 3, and then 6 self-reported being level 4. And then 1 facility did not self-report a level of maternal care. Based on the locate assessment, 6 facilities were less than level 1, 14 were level 1, 13 were level 2, there were not any level 3s, and then 7 were level 4. I just want to call your attention on this slide to where I say less than level 1. So locate refers to these facilities as less than level 1, whereas ACOG SMFM guidelines refer to them as birth centers. Our assessment is unable to take into account the accreditation process that birth centers undergo, including registration and site visits conducted by the Commission for the Accreditation of Birth Centers based on criteria from the American Association of Birth Centers. So we just consider facilities less than level 1 if they don't meet like the floor requirements for level 1. And on my next series of slides, I'll describe the most common reasons for discrepancies between self-report and locate assessment for Massachusetts facilities. So 4 facilities self-reported being a level 1, but locate assessed is less than level 1. The most common discrepancies for these facilities were related to anesthesiology and ultrasound services. To be a level 1, a CRNA, anesthesiologist assistant, or physician anesthesiologist needs to be readily available at all times or physically present at all times. And also to be a level 1, the facility needs to have either limited obstetric ultrasound or standard obstetric ultrasound with interpretation services readily available at all times. I'd also like to pause here because there has been confusion in the past and just clarify that by interpretation services, I mean interpretation of the ultrasound results. Next slide, please. So 9 facilities in Massachusetts self-reported being a level 2, but locate assessed is a level 1. The most common reasons for discrepancies were lacking an MFM, maternal echo, obstetric ultrasound, and general surgeon. So to be assessed as a level 2, an MFM needs to be readily available at all times for consultation on site, by phone, or by telemedicine as needed. Maternal echocardiography on site is also required for level 2, with interpretation services readily available at least on a daily basis. Standard obstetric ultrasound on site is required, and interpretation services need to be readily available at all times, regardless of the availability of limited obstetric ultrasound. And then finally, a general surgeon is required to be physically present at all times or readily available at all times. Next slide, please. The last big set of discrepancies that I'll discuss is for the 5 hospitals that self-reported level 3, but locate assessed is level 2. The most common reasons for discrepancies were lacking an MFM that is readily available at all times with inpatient privileges, lacking maternal echocardiography with interpretation services readily available at all times, and lacking specialized OB ultrasound with Doppler studies with interpretation services readily available at all times. Next slide, please. So because we hope that LOCATE results will help with quality improvement initiatives in emergency preparedness, I want to summarize what the hospitals reported here. Overall, nearly all hospitals have written policies for obstetric, hemorrhage, and hypertensive emergencies. Most have also had drills in the past 12 months, although hemorrhage drills were a little more common than hypertensive emergency drills. And just so you know, I took the facilities out of the denominator for drills if they didn't have written policies, just to follow the skip patterns that we use in LOCATE. So also you can see on the bottom figure, 80% of facilities reported any disaster response drills. 63% of facilities had disaster response drills that included neonatal units, and 69% of facilities had disaster response drills that included obstetric units. Next slide, please. On LOCATE, we also asked some general hospital statistics. Some facilities had missing data, and as you all know, facilities could pick the most recent 12 months that you had data for. So there's definitely some limitations to consider when looking at this table, especially compared to the other data sources that the state has. But LOCATE captured about 59,000 live births and about 66,000 deliveries. There were 3 recorded maternal deaths prior to discharge for a rate of 4.5 per 100,000 deliveries. 186 women required 4 or more units of blood for a rate of 28.2 per 10,000 deliveries. 196 women were admitted to an ICU for a rate of 29.7 per 10,000 deliveries. And then finally, there were 119 reported neonatal deaths for a rate of 2.0 per 1,000 live births. And the rates of maternal deaths prior to discharge, maternity patients requiring 4 or more units of blood, maternal ICU admission, and neonatal mortality were all very much in the range of what we've seen from other states that have implemented LOCATE. So the Massachusetts numbers are the first row of data, and then that second row are the other states that have completed LOCATE. And in the data I shared back with the implementation team in Massachusetts, there's also the opportunity to look at more of these statistics, and then also looking overall by facility self-reported level of care and by LOCATE assessed level of care. Next slide, please. So I'm going to defer to the implementation team in Massachusetts to discuss opportunities for what to do with the data now that it's been collected. But I just want to quickly note a few ideas we've heard from other states. These include conducting individual follow-up with facilities, participating in our multi-jurisdictional analysis by linking LOCATE data to outcome data, including the level of maternal care when the Maternal Mortality Review Committee reviews maternal deaths, identifying priorities in the state for QI or emergency preparedness, and thinking more about regionalized systems, such as the general availability of specialist services and transport within the systems. Next slide, please. So with that, I will stop and thank you for your time this afternoon. I really have enjoyed working with you all, and I think we'll maybe wait and take questions at the end. Is that right, Dr. Easter?
That is great. I just wanted to highlight just one comment up above in the chat from Dr. Sankey, which I thought was an important distinction and probably worth noting from the group about 3 versus 4 levels of care. I think Dr. Sankey is probably referencing the neonatal criteria, since we don't have sort of DPH derived maternal levels of care, but just wanted to maybe, I know that we are not entirely unique in that setup. I know Arizona highlights, the state that has been doing this for the longest only has 3 levels of care, that sort of idea. Carla, sorry, Carla, if you had other follow-up comments or just wanted to make sure that I correctly identified the root of the problem in terms of distinctions and levels of care, correct?
Yeah, I didn't have any other comments on that. I think you explained it well. And I agree that it can be very confusing.
That may be the only time I explain something accurately from the eyes of a maternal child health epidemiologist without some sort of footnote. So thank you. If there are no other questions, maybe we'll allow Godwin to dive into his results. So advance to the next slide and allow the boss to show us more of a specific look at how we're doing in Massachusetts with respect to delivering equitable care.
Thank you, Dr. Easter, and thank you, Carla, for your presentation. So I'll just briefly take us through what the additional questions we included to assess equity in Massachusetts. Next slide. Next slide. Yeah, so for Massachusetts, with the equity questions, we added 8 more questions to the locate tool. The first question assessed whether each hospital provides anti-racism or implicit bias training. We specifically looked at which group of providers get this training, that's providers, nurses, and other staff. We also looked at whether there are any systems or processes in place for patients' families to report discrimination or racism. We additionally looked at whether hospitals provide any educational programs for staff on peripartum racial and ethnic disparities. And then we further assessed the frequency of whether hospitals frequently address social determinants of health at debriefings and also at severe maternal morbidity reviews. We also did ask if hospitals perform a root cause analysis following cases of maternal mortality. And then the last question really was to assess if hospitals were interested in receiving any form of voluntary consultation from the locate team. Next slide. Next slide. So in terms of our results, generally, we think a good number of hospitals provide from anti-racism or implicit bias training to staff, over 83% of hospitals, which is pretty high. So we think that's something that we should try to continue. And then those few hospitals that don't sort of currently provide that, it should be a good idea to provide them opportunities to try to do that as well. Next slide. In terms of the type of providers, group of providers that get this training, an overwhelming majority provide training to all types of providers, OB providers, nurses, and then other staff. Just about 10% of hospitals provide training only to providers or nursing or other staff. Next slide. 80% of hospitals provide both, have a system for reporting discrimination or racism and bias for both patients and facility and staff. We noticed about this 80% translates to 32 hospitals, and 30 of these hospitals are actually the same group of hospitals that provide both, that have these systems or processes for patients and staff. Next slide. 1/3 of hospitals provide regular education on peripartum racial and ethnic disparities to staff. So this is an area that we think might, needs to sort of be improved, because we think that providing education to staff is very important and key, and trying to move away from just a small number of hospitals that provide this sort of training. Next slide. You can see that just by breakdown of the type of group of providers that receive this training, similarly to what we had before, on a majority provide to both providers, nursing, and other staff, but the numbers are pretty small. And we think that it might be great to sort of try to step this up a little and get more training to different groups of people at the hospital. Next slide. In terms of whether hospitals address any social determinants of health after adverse clinical events, we noticed that more than a quarter of hospitals always or mostly do that. And actually half of hospitals provide this sort of do this. 50%, half of hospitals do this sometimes. So that's like 50% of hospitals do this, which to us looks like it's a good thing. Just about 2 facilities do not currently perform any debriefings, and might be a good idea to try to get these 2 facilities also, try to address these social determinants of health after adverse events. Next slide. 30% of hospitals also always or mostly address social determinants of health during severe maternal morbidity reviews. Just 1 facility does not currently do that. But we think that at least on the overall, on the scale of things, at least more than close to more than 3/4 of hospitals actually do this always, most of the time, or sometimes, which is something that is encouraging. We should try to, continue to do that. Next slide. In terms of performing the root cause analysis, just one hospital doesn't currently perform a root cause analysis, that's at 2.5%. So essentially almost all 39 hospitals that took part in the survey do perform a root cause analysis and review for cases of maternal mortality, which is definitely something that we sort of highlight as a strength of our equity system in Massachusetts. Next slide. We also looked at looking at the number of hospitals that would be interested in a voluntary consult. We sort of highly think that hospitals should try to get some form of consult to help us, because PNQIN and the Locate team have processes that can support hospitals in improving their current equity systems. Just 60% of hospitals said possibly, showing some hesitancy to signing up for a voluntary consult, and just 32% of hospitals said definitely yes, they'll be interested in a consult. Next slide. We try to look at the level of maternal care, and we noticed that this, just based on the Locate level of care, hospitals which Locate assess lower were a little hesitant to receive consultation support from the Locate team. If you look at it, just 33.3% and 7.1% had a firm yes to requiring a voluntary consult. But if you look at those who assess at a higher level, at least 57% to 46% said they'll be more interested in sort of a voluntary consult. So we highly advise that hospitals sort of sign up if there's some discrepancy in their level of care to sort of receive the support that PNQIN has to offer. Next slide. We also looked at just any sort of whether hospitals that had a discrepancy in the assessment, and also those that had did not have a discrepancy, what sort of consultation they were interested in. The proportions are almost similar, but you can sort of see some hesitancy on the part of hospitals that sort of assess that way, where those discrepancies in their Locate assessment, their self-assessment. But overall, we think that the numbers pretty show that at least those that had a sort of assessed at the same level, definitely 37% or 38% would like to have a voluntary consult. But our main focus is on those who sort of had a discrepancy, and we think that possibly it's not a bad thing, but we would like people to be more sort of interested in receiving the consultation. Next slide. Yeah, thank you so much, and thank you for the opportunity to present on this, and we look forward to your questions. Back to you, Sarah.
Terrific. Thank you so much. Can I ask, while we are fortunate enough to have sort of the brain trust of the Betsy Lehman Center, the CDC, and the kind of Locate team here, do folks have any questions that are popping up now in sort of a burning manner? I will say, I know that Dr. Sankey was kind enough to clarify that there is reference to level of maternal care within the code within the DPH. It does seem, more aligned perhaps with levels of neonatal care. And while I think I don't want to put anyone on the spot from that group, I certainly was going to tempted with the idea because certainly things related to regulation are not my strong suit. But I think that certainly anecdotally in our conversations, that I don't think that the DPH perceives themselves to necessarily have distinct levels of maternal care guidelines. But forgive me if someone who knows a little bit more of what sort of the perinatal regulatory code, please feel free to interrupt. There's a question in the chat from Dr. Barr, and have we looked at geographic and race ethnicity payer distribution of levels of care? This was a concern in some of the early meetings with respect to equity. And I think she, hit the nail on the head as this being a sort of a theme that folks had a lot of concerns about very early on. I think that sort of speaking to the, I think not to spoil Dr. Zara's closing argument, but I think speaking to addressing those concerns with respect to equity. So within our implementation and access working group of the task force, we actually spent a fair bit of time, I'd say a quarter of our agenda, trying to see if we could explore this question using either publicly available data or data that perhaps we could ask our friends for some help with on the payer side. And this includes conversations with our colleagues from Mass Health who sat on that working group of the task force. The challenge becomes sort of using Massachusetts to do this sort of analysis is twofold. Number one, even if we could use like the high quality claims data that comes from Mass Health, for instance, it's not necessarily all payers. And then the sort of recent change to sort of the sort of ACO model would actually be basically when we were looking at this, which I think admittedly was in 2019, the sort of change in infrastructure was too recent that we felt like it wouldn't reliably reflect this practice pattern. Dr. Zara, interrupt me if I'm not describing things correctly from the data standpoint. But I think one of the hopes and one of the other big challenges to sort of that type of analysis is that there are no sort of data sources that have sort of covariates that you're mentioning here that we're interested in, but also would give us access to things like level of care. So I think one of the interests in sort of next steps and thinking about how we use this information, to address those concerns that you're so rightfully raising, is that we could potentially take some of the information that we have gleaned from Locate and try to explore those types of questions, which are not unique to Massachusetts. I think there's a dearth of evidence on this everywhere. I think Massachusetts is just in the unique spot that we have. We are fortunate enough to say that we have a population health issue in terms of, we're at the top of the good list, which is a great place to be after spending, the entirety of my childhood being at the top of the bad list in my home state. But I think that the overall hope is that actually the information coming from Locate in this sort of higher level de-identified way can help us understand a little bit more about the interaction between risk appropriate care, disparities in care, whether those be based on race, ethnicity, payer status, geography, etc. Do others have more thoughtful replies, or Dr. Barr, do you have other thoughts?
Well, I'll just add, Sarah Ray, this is Chloe, that I think we know that, it's actually relatively recent that we sort of just figured out what everybody's level was based on Locate, because we gave, based on the original results we got, it seemed like maybe some places needed a second pass through at their data. So I think I want to frame this all as a quality improvement project, which I think is probably your next slide, right, Sarah? Which is to say that I think no one totally knows what the right way to go about this whole leveling of care thing is. And to make explicit, I think a lot of people in the audience were on the task force, but this has been sort of a collaborative discussion about what could we get out of the CDC Locate tool and what does that mean in our state. There isn't really like a gold standard for levels of care, right? Like we're trying this for the first time. And so now that we are just getting our results back, I think the opportunity is to figure out what we want to do with them. And I would vote that we look at how are levels distributed across the state, and what does this mean, if anything, for specific networks of health? Because I think one of the things we know from our SMM data is that most places are pretty plugged in to networks of care, right? Very few, if any, centers don't have a place that they refer patients that are not risk appropriate too. The question is just, are there any networks that don't have the level of care that they need to serve their patient population? And I don't think we've had the opportunity to go into that yet. And we haven't given centers the opportunity to dig into their data well enough yet. So I think that looking at the equity implications of it is the right next step. Personally, that's my 2 cents. I hope that answers the question.
I was harking back a little bit. I know Dr. Barr's, your participation in the task force, I think, has been so helpful to sort of, I actually think that you're the person who first put that idea on my plate back sitting in the Betsy Lehman Center in person, wishing I had brought a sweater long, long ago. But I think that, we tried to use sort of data that was available to better understand. I think the other sort of challenge is that a lot of the sociodemographic characteristics that you want to look at also overlap significantly with urbanity. And so it may very well be that it's hard to actually, so if people living in an urban area are more likely to be near, tertiary care centers, if it makes sense, just because people who are in sort of either historically marginalized populations or are, subject to inequitable treatment within the system because of insurance status, et cetera, like those individuals may actually be getting risk appropriate care, but just by luck, not by intention, which is probably not exactly the goal. So I hope that having a little bit more information is instructive and sort of helping us better understand how to improve care for women in our state and eliminate disparities. I worry that it's going to be really complicated to figure out, especially when you just think about the geography of Massachusetts. Are there other folks who have questions? And certainly putting them, I think Charlie Carter is monitoring the chat as well. And so if it would be better to send a message to him directly too, that certainly is an option. I'm just monitoring the chat as well. Thank you, Kiara.
I was just going to jump in and say we could keep it informal and everyone can just unmute and talk.
Yeah.
We're all friends here, right?
I think no, and I'm delighted for that as well. It will help my ADD significantly. Just wanted to go back to Kiara's comment that each level within the perinatal regs does mention some maternal requirements. And so while I think the DPH has been very supportive of this being a quality improvement initiative, I don't necessarily have any insight as to how well perinatal regs align or don't align with locator levels of maternal care. And I think certainly that distinction, just making sure that I'm understanding things correctly is really helpful. Thank you, Kiara. To the rescue, almost always. Once a meeting, that happens to us. Other questions or thoughts? I was going to ask maybe Carla a quick question, if you don't mind, and hopefully it's not overly obnoxious. So one of the key distinguishing features between a level 2 and a level 3 center that seemed to be an area sort of causing consternation between self-assessment and locate assessment was the availability of maternal fetal medicine specialists with inpatient privileges sort of at all times. Distinguishing that from a level 2 facility, which just means MFM available, like for consultation, telemedicine, support, kind of in the phone a friend style. Do you have, so certainly it is sort of self-assessment, but do you have more experience about, or more information just from your experience in working with other states, like what that available for with inpatient privileges at all times means. Like, does that mean that hospitals need to have someone who comes in at 2 o'clock in the morning to physically see the patient? That sort of idea, just cutting to the chase.
Yeah, that's a great question. And to be honest, we get this question a lot because I think this is our most common discrepancy, like across all of our locate data. A lot of facilities think they're level 3 and would be a level 3 other than that MFM question. And unfortunately, the short answer to your question is, I don't know. We did use the exact language that ACOG uses in that in the guidelines that you had a screenshot of at the beginning. But you know, as a non-clinician myself, I don't want to overstep my expertise, and my expertise is certainly not clinical. So I don't have a great answer to your question. I can reach out to ACOG if you'd like and ask if they can give a more direct answer to your question, if it would be helpful.
That's very kind of you. Only, you know, I guess I could also reach out to the folks at ACOG because they're so kind. But I think just it was a common question that sort of got sent our way, and you gave that very diplomatic answer. And I think that, you know, regardless of what the letter of the law is for centers in Massachusetts to explore that question, we sort of invoked the spirit of the law that fine, like your hospital may not have a 24/7, like this is the MFM at home on call to come in at 2 o'clock in the morning. But you know, the idea of the spirit, recognizing that a lot of hospitals that do have MFMs with inpatient privileges have a very close relationship with those providers. You know, the sort of spirit of actually coming in to see a patient, you know, on the rare chances that it's needed, if you have inpatient privileges to do so. And that is something that, you know, in your heart of hearts, like Santa Claus is watching you, you know, would answer, then I think that would, we felt comfortable sort of encouraging those folks to answer that question in the affirmative. Are there other questions? Yes, and Dr. Sankey, I think, is highlighting the distinction in the like with their 2 OB units. So, you know, the distinction between, like a key distinction between level 2 and level 3 centers is that level 2 centers have MFM availability, whereas level 3 centers, they do have like full inpatient privileges, you know, with the idea to go in and lay hands on the patient, as opposed to just the sort of phone a friend or more consultative nature, if that makes sense. And I think the highlighting that practicality piece is also a really good one. You know, oftentimes the things that go down on labor and delivery at 2 o'clock in the morning, like fine, if the MFM person on call is, you know, fine. I, you know, that might be something I'd be helpful at, but I think there are a lot of, you know, just like I'm not the person you want doing your fetal transfusion in emergency. Like, I think, you know, a lot of times the general, the specialists in obstetrics and gynecology are going to be the things that require like an in-person intervention. I think falls more within the realm of a specialist in OB/GYN in a lot of settings, at least. So I think I'm getting a chat sort of in the background, which is kind from Charlie to remind me to talk a little bit more about the voluntary consultation piece. And I think maybe just looking at the time, it might be a good time to transition to sort of some of this closing discussion, which we've, I think, hit on just a tiny little bit. If we can advance to the next slide, only because it will make me happy to see my photo next to my now and forever, my residency mentor for life, basically, whether she's agreed to it or not, she's stuck with me, the good Dr. Zara, to see if you would be willing to share some closing thoughts.
Sure. So I got tapped to talk about this a little bit, just because I think I was fortunate enough to be part of the task force from the beginning. And I think I want to frame PNQIN's involvement in this and sort of this effort a little bit in the keeping it simple way. Like, the bottom line is that I think we knew that this was going to happen in some fashion. And by becoming relatively early adopters, we've had the ability to sort of say what we wanted that to look like in our state. And what we decided as a group, as a collaborative, was we wanted this to be a quality improvement initiative like other quality improvement initiatives across our state. One that aligns with other efforts we have going on, like looking at severe maternal morbidity, specifically looking at disparities in severe maternal morbidity and moving toward elimination of inequities in those. And so I think there's a next slide, right, Kaylee? Which will hopefully just kind of put the timeline of everything that's happened to date in perspective, which is that now, more than 3 years ago, DPH hosted a stakeholder meeting where we kind of decided this is what we want to do, as opposed to the other extreme, which is to take a regulatory approach. And I think part of this discussion of like, what does exactly DPH say, is because we very much, as the obstetric stakeholders in the state, wanted to make sure that this wasn't something that was regulatory, but which is the route Texas has taken, but rather something where we could learn from each other and support each other on whatever journey it was toward our kind of risk appropriate care across the state. Betsy Lehman hosted our next meeting, which was the following year, about 6 months later. And then COVID happened last year, which kind of put a hold on everything, which is part of why the timeline looks like it does. We were able to pick that back up this spring, about a year after we had paused everything. And the locate tool came out with the addition of our equity focused questions to kind of assess what were centers doing, not just with respect to risk appropriate maternal care, but with respect to equity appropriate maternal care and what structural measures were in place to work toward equity. And so kind of where we're at now is the first iteration, I think the end of our first PDSA cycle, really, which is let's look at what our results look like and see what we need to do to make this process better moving forward. I'll take the next slide. We certainly just want to highlight all of the stakeholders that have participated in this. I think one key part of any QI journey is making sure that all of the stakeholders are in the room. To me, I think we've tried really hard to involve as many folks as possible. Surely there are always some voices that we could feature more prominently, and usually those are patient voices. And so I think as we think about what the needs of our patients are and speaking on their behalf, if we aren't able to have them in the room, I think the equity question is front and center. And so to Dr. Barr's point, which she raised early in the process, like, how are we going to make sure this doesn't impact anyone in our state? Well, we are the group that gets to decide what this means. So I think we'll keep having that conversation, and really that's, none of this has any regulatory impact at the moment. And so that's what I want to make super clear is PNQIN doesn't have any regulatory, we are not a regulatory agency. And though agencies have participated all along the way, I think it's all from the standpoint of figuring out how to make quality better. Next slide. So we're giving everybody will be receiving their final reports, I believe today or tomorrow. And I encourage you to go back to each other. Sarah Ray, feel free to jump in if I'm wrong.
Yes, no, I'm so sorry. So we are, we're hoping to get the reports to everyone by the sort of 19th is our internal deadline. Okay. Recognizing it takes a long, I hope you'll be happy with the final report. And then I think that just because Charlie had asked me to mention this, that, one of the things that we're hopeful is that your final report shows like overall data so that you could, in theory, put it in front of someone who has no idea what levels of maternal care is and like read it, understand sort of what we've done in this state, understand how your results fit into that state and how actually you want to take these results or not, and sort of direct your own priorities in your practice. And I think one of the things that we recognize along the way, even though we've been hopeful to try to follow a process close to what ACOG had modeled in terms of site visits, the combination of just bandwidth plus COVID isn't going to make that possible. And it may not be necessary for the vast majority of hospitals based on our initial review of that question of, would you be interested in this consultation? That being said, at the very end of the report, the very last thing is like a little paragraph describing more on if you think it would be helpful to spend a couple of hours to sit down, go over your results in detail, talk about it more within the framework of levels of maternal care. Whether your self-assessment agreed with your locate assessment or not, like we'd be extraordinarily enthusiastic to do that times 40 if that's what is asked. So I just wanted to highlight that sort of take home point of the report, since there's going to be a little bit of distance between this time and when you get the report by about a week or so.
So that's great. I mean, I think that's a segue into how do we use this to sort of start the next PDSA cycle, really. And I think that's, you take it internally, you use it to figure out what resources you have or what resources you need, and feel free to reach out to PNQIN, where we are happy to sort of support that in whatever way possible. From the standpoint of the equity questions, I think I just want to highlight that implementation of so equity is sort of the 5th R. Respectful care is going into all the new AIM bundles that come out. So equity is the underpinning of everything we're trying to do, really. But there's going to be a big push on that in the coming calendar year. So look for that in later 2022. So a specific sort of bundle implementation coming next year. And then I do want to just acknowledge that we are not the only group thinking about levels of maternal care, since the ACOG and SMFM came out with this initial statement. As I alluded to, some states have taken a regulatory approach, and some states have taken an approach tied to reimbursement. And I believe the Joint Commission is now quite interested in maternal levels of care. And so we certainly are not sharing data with anyone. There is very much a use agreement that sort of means this is your data, you get to keep it. But I do want to acknowledge that other organizations are thinking about it. So I would look at this as the ability to have sort of a preview of what's to come, to know if that's what you want your level to be before the Joint Commission decides to look at it, whenever that is going to be. Then I think that it's just a useful tool. Hopefully it can be a useful tool. Obviously, I think the other piece of this, we haven't planned any further webinars to talk about sort of implementation, but if there is a need to talk about what do you do with your level if you don't agree with it, or, you know, like I think if we need to do more conversation about this, there's definitely room for that. And there's definitely a lot of space for ongoing conversation. So please feel free to reach out and just, you know, express any concerns as they arise, or any confusion. Like we really do want to be a resource as a group.
Thank you so much. I so appreciate. Now and forever, she will say things that I'm thinking in a much more clear and palatable way than from intern year on. But I think, you know, we've highlighted on this slide some of the groups that have been really supportive as stakeholder organizations and kind of levels of maternal care. And like, obviously ACOG came up with this idea, but Mass ACOG has been very supportive locally. Only because I see Dr. Beatty on the call, want to highlight, you know, his willingness to include updates about levels of maternal care in sort of a, obviously a de-identified way, but just as a framework, almost quarterly at this point on their CRICO chiefs call. And so I think if there are other organizations that you feel plugged into that think that folks could use this update, that's another place that we're more than excited to share enthusiasm. And just advancing one more slide, and just I wanted to close with some very tangible next steps, because I'm a checkbox kind of person. And so this week, and meaning within 7 days, you will have a report with your individualized information. Our hope is to potentially get it out before the 19th, but that's our kind of hard internal deadline, recognizing how much flex there can be. And that will have the information about sort of the optional, like coaching or consultation or whatever you want to call it, if we can be helpful in helping you understand your results, or advocating or passing along feedback that, you know what, this is just really silly that this is even something that's written into levels of maternal care, or what have you. And then I think that importantly, part of what Dr. Zara was referencing is we're very fortunate to have part of the agenda for the upcoming PNQIN board meeting, which is an advisory board of stakeholders, including patients and patient advocates, to try to talk about our findings and think about how we can consider levels of care in ongoing projects, as Dr. Zara referenced. And then she also brought up this the rumblings of the Joint Commission's interest in this space as a voluntary certification that you can get, kind of like being a stroke center or what have you. And I think that we are not at all interested in per se having a hand in doling that out, but I think we are extraordinarily committed to advocating for this framework that we've been committed to all along, this collaborative quality improvement focus framework. We had the opportunity to share our work in Massachusetts through ASTHO, the Association of State and Territorial Health Organizations. I practiced that 3 times, which basically is sort of like the governing, the ACOG for departments of public health is my take home on how to describe it. And certainly in July, we were fortunate to be given part of the agenda to present alongside folks like Kate Menard and Sarah Kilpatrick and Chris Son, who came up with this framework. And then we're fortunate to have been invited back to join in November, at which time they're discussing their follow-up meeting. And I think I'm highlighting that only because I think that we were unique in the 6 states that they chose to have present about their work, in terms of we're not the only one happening through a PQC, but the only one happening through a PQC distinct from any sort of like regulation or legislation. We're also the only I think we were most explicit about our discussion of equity. And part of the reason I'm highlighting that is not to, pat ourselves on the back, but to show how we are fortunate to be in a place where we can, I think, innovate in this through this population health approach. And I think that is relevant when you're thinking about the Joint Commission's interest in this space, because certainly I think if you're coming from a public health framework of just, set a standard of care and encourage others to meet it without thinking about the indirect consequences. That I think is the concern with regulatory involvement. And we have a lot of experience, thanks to y'all's participation, to be able to advocate as to why that may be a concerning approach. So with that in mind, I'll advance to the next slide, which includes Kaylee's email and my email. And I'm happy to linger around if there are others who have questions for a moment. But if there's anything that we can do to be helpful now and forever, please don't hesitate to reach out. But moreover, I just personally, knowing that I'm over, I had the pleasure of going to this DPH coordinated stakeholder meeting very shortly after the birth of my kiddo. Not to be overly personal, but he turned 3 a month or so ago. And I don't know what milestones are more impressive. The fact that like that little 8-pound blob can speak in full sentences and walk, or the fact that we were able to come together as 40 hospitals facing very different challenges in very different parts of the states in the middle of a global pandemic with unprecedented challenges to our healthcare system, and get this done. I'm so incredibly grateful to be a part of this incredible team, and to have the opportunity to collaborate with people who are so incredibly passionate about women's health. So thank you for your time, expertise, and can't wait to see you all soon.